panel, which is going to be very important in talking about what are the hot topics. What are other things we need to address that are certainly not there yet that we want to make sure that we're going to have included so that we don't end up with a great idea for a rare disease drug strategy, but all the important pieces in terms of how does it fit into the system? What are all the other kinds of infrastructure or other kinds of supports that are needed? How are those going to work? And certainly beyond it, we keep coming back to where should we be investing in order to make sure that we're going to have the best optimal kinds of access. So this will be our last panel, and I think it'll be very important. We recognize again, I'm going to say now is that we'll probably have two more webinars. Maybe not necessarily before the 26th, I don't know. I think we're all tired of webinars. I'm certainly tired of webinars, but if we do have, there are a number of topics that we just want to make sure we can cover. We have not in any of this really talked deliberately about what the role of private drug plan and the public drug plans are in a single rare disease drug strategy. We need to directly address that. We also do want to be able to talk about, what are the, beyond just the infrastructure, right? What are the requirements that we're going to need in terms of making this system work? Just to let everybody know, there were 3 additional topics that were announced by Health Canada in their consultations. My understanding is those consultations are open to everybody. If not, we will find a link for you. Very important to address, but because they're going to address some of the things that we have not yet, including what should be the scope of rare diseases. Is there a definition that we would want to talk about that would be inclusive in a rare disease drug strategy? Much of what is in that strategy seemingly address what we call high cost drugs and seemingly ultra rare diseases, but that may or may not be the limit of what we're looking at, nor may that be the best way of defining it. There's also a request for understanding, how are we going to deal with financing and funding? Is there a risk pooling scheme? What are the ways in which funding is going to be done if there is a single system? And then, of course, we need to also talk about the rest of the infrastructure, especially around data collection, patient registry. So those are important topics. If you have not seen that call, we'll try to make sure it's available and people can take a look at kind of what the options are in terms of participating. This is very, very important as well. Okay, so without further ado, I'm going to move into our first panel, which means that I would like to invite all of those who are on that first panel, the Chung family, Dr. Campbell, Dr. Ward, Dr. Aon, and Charmaine Brown to unmute yourselves and to put on your videos if you can. And we're going to get started with that first panel. Oh, yes, of course, that was good. Immediate responses here. What I'm going to do is I'm actually going to start with the clinicians, if you don't mind. We'll have an opportunity to discuss. And I gave you sort of a heads up on what we might want to discuss. But before I throw you into that, yesterday, those of you with us will know that we actually played 2 short videos, one which featured the Chung family and what they're hoping to get access to, and that is to be able to get access to the gene therapy for spinal muscular atrophy for their children, in addition to their continuance right now in terms of on Spinraza. The other video featured the Brown family, all 4 of them, and really addressing why there is an urgency in terms of getting access to the gene therapy that has just been approved but is not yet funded. So in both cases, we've got a therapy that is available, has been approved in Canada, but is not readily available yet to the patients. And so we won't show those videos again, but they were shown, and I think it really had a very powerful impact in terms of understanding what it means to the patients. But what I want to do is pivot to the physicians here, because this is such an important asset for us. And those of you who work with the clinicians as patients or as colleagues or as other stakeholders in the system know what the key role the clinicians play. And most of them are clinician researchers, so they play an even more important role. I mean, what do we ask of them? We ask them to be aware of all the new therapies that are coming in and be up to date. We expect them to be able to provide us with the most expert guidance in terms of how these therapies work, for whom do they work, and we really rely on them to be able to provide that information. Sometimes, even as these therapies are emerging, the clinical trials are emerging, we also expect them to be, the consultants into the system, to actually serve as that bridge, sometimes to make the case for the access to the therapies, to provide that unbiased opinion, and to really serve as that critical expert voice. And sometimes I think it huge challenges to them. We expect them to serve as the advocate, the advocate for getting access, and especially when the patient comes to them. We also expect them to also serve as that, adjudicator, sometimes to give the hard news, maybe to the patients and the families, that this is not the right therapy, that this is not going to be available. And sometimes not going to be available, immediately, or not even available as that right therapy. So we're asking a lot of them. And then, of course, when we ask them to actually be that applicant, sometimes it means filling out request after request, and not easy requests, and requests that take a lot of time and work, for which they are not really part of their actual paid job. That we know they all do it because that's what they do in terms of on behalf of the patients. And so we ask an awful lot of our clinicians, our clinician researchers in this environment. And I know they step forth and they do it, and they do it gladly. But we also know that we need a system that is going to be less burdensome. And we're going to need a system that's much more predictable. We need a system that's going to be much more streamlined, because, hopefully we get more and more of these therapies coming in. And we already have, for some of these patient communities, as you know, 2, 3 therapies that are already available. And it has been, we know, for every single one of those that are in there, has been a really Herculean support from the clinicians that have made that happen. I do not know any therapy that we've gone to bat for in terms of advocacy that we've been able to make any inroads on without the commitment and the support of that clinician community. So we ask a lot of the clinicians. And so I'm really happy to have the opportunity to have 3 of them here. 3 who are really, I think those of you who know them as clinicians know how much they are a champion, and those of you who know of them in the way in which they've supported the work that we've done recognize how much they contribute. So I'm really pleased that you also were willing to make the time in what I know is continuously very busy schedules to come in and to give us some words here. So I'll ask, maybe easiest to ask you to introduce yourselves when I ask you to speak, and that way it'll be a lot easier than me trying to go through it all. But I've kind of got the same questions for you all to begin with, and that is, we know, and this is kind of the heart of it sometimes, is that the patients and the clinicians may not always see exactly the same way in terms of a treatment, in terms of whether or not it's the exact right one, the balance between the benefits and the risks, especially with some of these newer therapies that are coming in there. How do you think that gap can be best addressed in terms of, patients will go online, patients will talk to their support groups, patients will also do their own research, and they may have different aspirations, and they will come to the clinicians to ask for, sometimes not advice, but to really kind of press their own opinions onto the clinicians as well. How do we do that? If we're moving forth in a more optimal drug strategy, what do we need to put in place so that we can have a better understanding, maybe on the part of the patients, and making it so that it's much more effective for the clinicians in this process? Or maybe you see the whole situation quite differently than I do, because I'm telling it to you from the way I see it as an outsider. What would you say? Maybe I'll start with, if you don't mind, Craig. Yeah, I'll start with you, because we've dealt with you in so many really challenging situations as well. What do you think we need to build into a rare drug strategy that would allow us to assure that we've done that ability for the clinicians and patients to work in the best way together?
Thanks, Durhan. And really, thanks for having me here today. My name is Craig Campbell. I'm a pediatric neuromuscular specialist at Children's Hospital Western Ontario in London. And I, have had the experience of journeying with families with rare neuromuscular disorders, through the spectrum of, kind of imagining clinical trials, way back when, actually, realizing them, and then, this often unsatisfactory, gap between a clinical trial and actually, trying to get access to a drug. So I feel I do, have journeyed that difficult road, and I'm happy to share a little bit, because these are, challenging, issues. And when I reflect on what may be, really effective ways to smooth that pathway, I think in both kind of a macro, level and a micro level. I should pause here also to say, Durhan, I do appreciate the sympathy you extend to us but the reality is we do have to do better, and we can't, as a clinician group, and we can't hide behind the busyness of things if we're going to make a difference. And so we have to come forward and partner. And so that's my call out to, to the clinicians too, not to, get bogged down in the day to day, and lift up the eyes and see the long goal of when we commit to, thinking about rare disease, what we can do together, not only as a clinician group, but in partnership. So two things I think about it, and I'll start with maybe the macro, because I think this is really where things help. When I think back about the journeys we've had both in SMA and DMD, the things that have really been most effective in my mind is one, coming together as a clinician group and having a clear consensus statement. I mean, often that does a lot simply to, make it transparent, make it evident, make it public. What where our headspace is around these treatments, rather than people having to wonder, will this clinician be interested in giving therapy and will this not. We have a sort of a consensus statement. I think that's very healthy. The other thing we have often committed to in the neuromuscular space is rapidly adapting some of our real world data collection so that we're relevant to the situation at hand. And we did that in SMA. We quickly changed the kinds of data we were collecting in our national database so that what we felt what would be useful for the whole community, patient community, regulators. So we did that, very quickly. We advocated for panels of experts to adjudicate or help decide about compassionate release, where there's a gap between approval and funding. We organized panels that included input from industry, from patients, from impartial chairs of those committees to say, is there a way we can, adjudicate all these requests coming in a way that is fair and provides a more collective thing. We trained our specialists across the country in motor training. We agreed on what would be, the outcomes that we felt. So it was all very clear. If you do these things, it's all, we may not agree all the time, but at least it's all very clear, and people can then know where the, the kind of the touch points are, the things we can fine tune. And I think that's, those are the kind of things we need to do at a macro level. At a micro level, of course, always those therapeutic discussions with individual patients are, kind of really important to understand their preferences around treatment, to understand what their goals are, to set goals, to be clear. And that obviously happens every day in all sorts of medical decision making, but it's particularly important here. And one of the things that I feel we really need to bring into the rare disease decision making space is this concept of shared decision making, and impartial decision coaching around these difficult decisions, because it often is so emotionally charged. And I'm proud to say here at the Children's Hospital, we have a shared decision making coach who can come into those scenarios and help with decision making. And Muscular Dystrophy Canada has contracted and worked with us to provide that shared decision making across their system navigation across Ontario. So this is a really great resource, when there are challenging decisions in front of us. So those are my sort of initial opening thoughts.
That's amazing, and certainly we've been the beneficiaries of that. We actually had Muscular Dystrophy Canada on yesterday talking about their services, and certainly I think that relationship, as you say, that really is powerful when you look at it. But beyond that, certainly we were very appreciative. I think when Newspring was first coming in, and we realized that you especially having organized with the clinicians already had in place those kinds of guidelines and those kinds of decision-making criteria that we could, really call upon to say, okay, what, there are reasonable ways that we can bring this therapy in a way that's going to be monitored. It's going to be, making the best use of it. So that was pretty impressive. And hopefully, we can look at it in terms of other disease areas as well, because it's going to be key to many of these therapies coming in as we're talking about. I want to pivot over to you, Leanne. I mean, you like Dr. Campbell, Craig, you're often kinds of point to, or pointing out to us as sort of a patient's doctor. These are people that the patients often talk about in terms of their best experiences. But maybe you can, building on what Craig says, maybe you can give us some specific examples in terms of how this has worked in practice for you, in terms of maybe not necessarily specific cases, but what does that mean in terms of your practice and, with regard to, bone diseases here.
Mm-hmm. Well, thank you, Durhan. It's a pleasure to be part of this panel. I'm Leanne Ward, as Durhan said, and I'm a pediatric endocrinologist at CHIO in Ottawa, and I specialize in bone diseases of childhood, which by definition are rare. So that's how I've fallen into the rare disease space. And I'll just start by saying that I echo everything Craig said so comprehensively, and I'll try just to build on what Craig said so as not to repeat, but certainly endorse everything that Dr. Campbell has said. For me, how we can bridge this gap that you're talking about is, in addition to what Craig said, I think we need centers of excellence that can provide patients with the standard of care in terms of what is available diagnostically and therapeutically in, for example, 2021. And then at the same time, layer into that standard of care approach information about what's coming down the pipe, what's new, what trials are available, and provide patients with this rare situation, the comfort of knowing that they're working with health professionals who understand their disease, who have the tools and the collaborators around them to provide that basic standard of care, but also an eye to the future to help patients navigate trials and get access to therapeutics that are coming down the pike. So if in my dreamland, if you will, I would like to see centers of excellence scattered across the country, and so that no matter where you live, you have access to a physician and a healthcare team that can deliver on that level. And then in that context, when you talk about the disparity between perhaps the patient's vision and maybe what the clinician is thinking, I think, just as Craig said, it's so important to think about the rare bone disease space, rare disease space in general, in fact, medicine in general, as a shared partnership. I always say to my patients, I'm on this journey with you. You're going to teach me. I'm going to listen to you. And together, we're going to figure out a path that's appropriate for your specific situation. Because although rare disease does bring some homogeneity to a patient population, and make my case X-linked hypophosphatemia, osteogenesis imperfecta, within these disease groups, there is tremendous heterogeneity in terms of the patient's needs, their own goals for themselves in terms of their life and their quality of life. And so having an intimate understanding of the patient and where they're at and how those needs can be addressed with the available information is really important. I have a lot of conversations with my patients about what we can offer that is deeply rooted in the evidence that's come from clinical trials, for example, or even clinicians who have done studies just looking at their patient populations retrospectively over time. And I think it's really important, after understanding the patient's needs, to have a dialogue that goes like this. This is where you're at. This is what we know about your condition. This is the way this drug or this therapeutic approach can help. These are the aspects that are not addressed by the drug, so don't overpromise. And this is what we're doing to try to get at those unmet needs. And I think, it never ceases to amaze me the extent to which patients are ready and willing to receive information as long as it's evidence-based, true, honest. Even if it's not exactly what they want to hear, they want to know they're getting good, upfront, honest, evidence-based information. And I think that is a huge part of what we need to do as clinicians. The final thing, sorry, go on.
No, go ahead, sorry. Yeah, no.
I was going to say the final thing that I would just like to say, and just to chase a little bit what Craig said, is that I think it's really important as we go forward in this access to drug space to think about having national expert review committees for drugs and who receives treatment for a number of reasons. One main reason is I think we want to be sure that we continue to deliver equitable messages in terms of drug access and not have them province specific. I hold equitable access to care and delivery of care near and dear to my heart. I also think that the people reviewing the therapies need to understand the disease space intimately. And there's only so many of those people across the country, although we're certainly trying to empower more and more all the time. So a notion of national expert review committees to review access to therapies, including clinicians with very specific expertise and knowledge of the literature and the clinical trials, I think is going to be important going forward. So I'll stop there.
I was actually going to push you to that last point, so I'm glad you came up with it, because I think what we've seen the real challenges, right, is where we do not necessarily have agreed upon expert committees. And then the cases get decided on a case-by-case basis, and they get decided by reviewers who are not necessarily experts. I mean, they may be great clinicians, pharmacists, or researchers in their own right, but not necessarily in that disease area. And that's where I think a lot of the challenges come in, and it's certainly not just in terms of consistency, but the I think the satisfaction that we have actually provided the best kind of a case to everybody. So that's great. I'm going to pivot then over to Dr. Ayan, and I'm going to ask you a little bit differently though, because you're in a somewhat of a novel space, and I had the opportunity of meeting some of your colleagues as well. So what do you think is necessary in order to get, clinicians, mostly clinicians, practicing clinicians, to the point what Leanne's talking about, and certainly what Dr. Campbell was able to create for the neuromuscular and especially SMA community. I mean, especially when, clinicians are maybe in that disease area newly coming into these kinds of challenging rare disease therapies, because we've got lots of areas in which there's been no previous therapy, at least none that require this level of adjudication. What do you think are the challenges, and how does one get that kind of collaboration, cooperation?
So thank you, Durhan, first for including me in this important workshop. I'm Elise Léon. I'm at the Hospital for Sick Children in Toronto. I'm an ophthalmologist, and I focus on inherited.
Can you get a little closer? Your voice is a little bit faded.
Yeah, I can't find my microphone. So is this better?
Yeah.
Yeah, that's a little better.
I'll be in
yeah, that's much better.
I'm at Sick Kids in Toronto. I'm an ophthalmologist, and I focus on inherited retinal disorders, which is also a group of rare diseases. One of which is what we call Leber's congenital amaurosis, which is a very early type of retinal degeneration. So the slang word is LCA. And it's very genetically heterogeneous. And there's a subset due to mutations in the RPE65 genes that has undergone clinical trials for gene replacement therapy, showing safety and success. The product is now approved by Health Canada, CADIT, INES, but we're not going anywhere. I've submitted compassionate request, and I've hit the wall in all instances after multiple requests. We have several limitations. One is what we call ocular genetics, the field I'm in, like probably the rare bone disease, until recently and still was not very popular. Like it's deemed complicated, non-lucrative. You don't have much to offer. So in the country, there's 5 or 6 of us that are properly trained to do this. And half of those are over 65. And that's a huge concern. It's been really hard to train people. And so I really welcome your comments, because what you're telling me is that we need to work harder to train the more general eye care providers on the importance of this. So I'm working on the paper for that, and we need to do our share of raising awareness and educating people so that they're included in the journey. And that's not easy, because like you say, Craig, everyone's busy and it's just hard to get anyone's attention. So I would say that's the major hurdle, is the awareness because of the rarity of the disease, because blindness is invisible. Like you don't look blind. And until people can cope, they try to hide it as much as they can because there is taboo discrimination, and it's silent. Like, so people are quiet. And so I'm told that the only thing that's going to change in getting approval is noise. And I was like, well, that's a problem because it's a silent community, and they don't want to hear from me. They have to hear from the patients. And so luckily I have this guinea pig family, the Browns, who are extraordinary and allowing me to push them forward in the scene. And so those are the big hurdles. I have a few questions because I really enjoyed all your input. One of them is, you said, Craig, that you have a consensus statement that you've put together. I'm just curious, to whom is that statement for? Is it Health Canada, or is it to your professional community? And I assume it's regarding the importance of advocating for treatment. Like, we have a national advisory board for this, but we haven't issued a statement.
Well, I'll answer that just quickly. I mean, we were a fairly conservative bunch, so we actually, had many meetings as a clinician community, and it ended up settling on publishing that in our, in our national neurology journal as a consensus statement. We got it through rapid review because that's what people felt comfortable with.
Yeah.
And felt would be a lever, if it was peer reviewed versus a press release or, something. I mean, those can be effective tools, but this was the route we chose.
Yeah, we wrote with a colleague of mine in Montreal, like most patients are in Montreal and here in Toronto. We wrote an editorial for the Canadian Journal of Ophthalmology, but it wasn't a consensus statement. It probably would have been more powerful than just write an opinion on the topic. I have another question is your panel of adjudicators. So when I applied, and I've had discussions with the Ministry of Health regarding my requests, and they say, oh, well, we're going to need to have this reviewed by experts. But in our case, the experts are the users. It's a very small community. So how did you establish your panel of adjudicators, and is that for the request of some special treatments to the Ministry of Health?
So again, I'm a very, sort of collaborative collector. I mean, I think when there are gaps, and there are along the way, working with the companies to understand what their free goods or their compassionate release programs might look like. I think we put many times our individual clinicians and certainly our patients in this mad scramble to find the right doctor who's, as Durhane said, who's going to advocate strongly for you. And in fact, that disadvantages many families who do not maybe have the resources so if there's a common adjudicating panel of experts chaired by an impartial person outside then that's a nice mechanism for taking requests through to actual approval. I mean, there's many steps we went through. I can't go through it, but I think it has to be obviously at arm's length to the pharmaceutical agency, include the right people. There has to be a system, a common template for submission, all these things that we went through. But anyways, suffice it to say, I think it's something we need to look at more often. I just feel badly when everyone's running around panicked and trying to get their child in the right spot in front of someone. It's not fair to the families.
Okay, at the risk of allowing Elise to kind of take over my entire conference, but this is such an amazing discussion. It's exactly what we need. I'm going to make the suggestion, and it's actually more work for you guys. We would love to host an entire forum just on this. And it's one of the pertinent questions that Health Canada is asking, how do we set up, these data registries and these patient registries, but setting up these advisory panels. And somebody put in the chat line what we've known a long time. One of our first ones, of course, with the Canadian Fabry, advisory panel, expert panel. And that still stands as a model for, how we did it under huge pressure at the time. And people keep asking, how come we haven't been able to do that again? Well, of course we have, and we've been able to replicate it in many settings, but not with the kind of support that panel actually got from all the stakeholders. So I'm just going to pivot, maybe it's a natural opening to go to Charmaine, if you don't mind. So we've heard from the clinicians in terms of what their role is. And Charmaine, would love to have you talk a bit about, what you heard from the clinicians here, what you appreciated in that, and certainly what you see has been most helpful to you in terms of your requests. We did do the video yesterday, but you might kind of just do a small capsule in terms of what you are requesting.
First of all, thanks so much for having me. I feel very privileged to be amongst amazing individuals who are doing work on behalf of families across this country in spaces where people may not even know what the struggle is, and you're doing the work. So thank you for having me. I'm a parent of two incredible young people who have retinitis pigmentosa and are very much in line and receiving the gene therapy that has just become available in Canada. And we've had the privilege of our daughter receiving a similar treatment when it was in kind of experimental mode several years ago, and have seen the benefits of it, and are hoping that our son, who has a more progressive and aggressive form of RP, to receive it before he loses any more vision. And we have noticed that he has lost a little bit more vision in the last few years, especially going through puberty, which is a natural course of RP. And so this is essential to the work that you're doing, and the conversations that you're having right now is essential, and really, as a parent, warms my heart. As a human being, makes me really proud as a Canadian that this work is being done. But as a parent, it reminds me that not only of the importance of it, because I understand the importance of it for my own child and how that will benefit them in the future, will allow them to be more independent, will allow them the freedom of knowing that they're not going to be blind. Just having that reassurance that I'm not going to be blind, that I'm not going to live my life. And Dr. Han has shared that with us, even when my kids were like very, very young, and said they're not going to live their life with this disease. And we've held on to that as a family. And we're at that place right now in history where we have this gene therapy that's going to halt the progression of this disease. And so that, my son, who's in line for it, will not have to worry about losing his vision, which is a concern of his as a 17-year-old who's lived understanding, and we've been very open and honest and about his eye disorder and how it works, and how he's had to navigate every aspect of his life, and the intersections of that, being a Black male as well, all play into how he navigates spaces and opportunities and lack of opportunities, etc. So the work you're doing is essential, and we are doing our part in terms of the advocacy. Both my son and daughter are spreading the word out. My son did a TikTok a couple of days ago. We're at 130,000 views and about 5,000 shares, and we're asking people to email their MPP, not to just, oh, here's the issue. Oh, hey, I have RP and there's a gene therapy. It's not just that. It's giving the information, sharing the information, and then saying, take action. It's time for us as Canadians to take action. If we want to care about each other and show that we care about each other, this is how we do it. We ask our governments to take a stand, to realize the decisions they make are about humans and human lives and people's day-to-day life.
Well, thank you so much. Charmaine, I'm going to have to interrupt because I think we're going to run out of time. We've had requests to have that TikTok shared, so we will definitely make sure that people get it. And as we said, we were able to show part of the video yesterday. And those of you who saw it realize that, yeah, Charmaine has two incredible children and who have actually taken on that responsibility in a great way. But we can see where it comes from in terms of the parents as well. I'm just going to take the last bit of time then and to ask Kim Sung, if you wouldn't mind, kind of just sharing, you know, we had an opportunity yesterday, as I said, to show the video, but just, you know, can you share with us what you've heard from what you've heard today? What do you hope will happen on behalf of your twin?
First of all, thank you for having our family here today. And I feel privileged to participate in this panel. Okay. We were told that our girl might not eligible for case by case, and however, we have been turning down several times that they might not qualify for funding. Sorry. And there is not enough evidence for kids over 2 years to get Fujian-SMA, and also that Fujian-SMA only works for SMA type 1 under 6 months old. Therefore, we have been searching and asking people around the Facebook and Instagram who have kids at over 2 years and they got Fujian-SMA, and we found the information and we provide to our girl neurologist. However, we were told that this is not enough information yet, and no one in Canada who over 2 years got Fujian-SMA yet. As far as I know, there is at least 2 kids over 2 years already got Fujian-SMA in Canada, and there are all over the news. And we mentioned to our neurologist, but he said there was no record of it. At this point, we are as a family, we are feeling down and frustrated. And time is running out for our girl, and we know that our girl are in the risk of losing eligibility for the Fujian-SMA as they are over 2 years, but they are under the criteria of weight like 21 kilograms. But mostly in European country, I know that they are doing for kids over 2 years, which is under the weight of 13.5 kilograms. And our girl is very close to that right now. They are 10.5 kilograms, right? And we are hoping that our kid could get treatment before more damage could happen to them. We are hoping that one day there will be a neurologist who willing to step up for our kid, applying case by case and provide them the Fujian-SMA. Because we know that Fujian-SMA work to replace broken gene and it stopped the progression of SMS. And while my girl on the current treatment, which they have to go through painful treatment like every 4 months for Spinraza, and they cry most of the time. And after the treatment, they cry and they say to me, "Mama, boo boo, I feel so hurt. And I cry every time I heard them." And all this struggle my girl go through, I hope they just get one-time treatment that work for them. Because as far as I know, they already got 5 injections and it's been very painful to them, and I don't see improvement so far on my girl.
Okay, thank you very much. I just I appreciate very much, and again, I wanted you to have the opportunity, as you say, to make the statement. And again, you know, it's always very challenging, as you know, in the environment in terms of the balance, in terms of what is in fact the evidence, what's known, what is also available. But we really, really want to support, you know, patients and families being able to have a voice and being able to be part of that kind of decision making. So thank you folks very much. And I know you've been doing the advocacy very, very hard on behalf of your girls, and we can certainly see why. So I appreciate that very, very much. It's a huge challenge. I think this is just to pull it all the way back, you know, the reasons why we're doing what we're doing, right? And we do need to move into the next panel, is that, as Dr. Campbell said at the very beginning, we've got to have the ability to have consistent guidelines. We've got to have the, you know, the experts that are able to be called upon to make these kinds of decisions, to have that kind of respect. And I think, as we heard from Dr. Aon and Dr. Ward as well, you know, when you've got the experts and they're able to be the ones that are making the decisions, I think that's on the best behalf of all the patients, all of the clinicians. So we're working hard towards seeing how we can actually have those kinds of national agreements. So we appreciate so much your bringing, you know, your specific case here. We're certainly going to continue to do everything we can to support you. And we have
Thank you
been,
so
as I
much.
say, very lucky here in Canada in that so many families have been able to get access to treatments, certainly starting with Nusiran as a real lifesaver for many of these children, and also in some cases getting access to the gene therapy, which we recognize as having a significant impact in terms of quality of life. So we're going to continue to work with you and appreciate so much you're bringing the whole family here. Thank you again.
Thank you again for this opportunity.
Thank you. So what we're going to do then is really, first of all, I just want to thank the clinicians, the doctors that were here. We know that you're all probably in clinic at the moment, having to scramble in and scramble out to do this, but we know you do it willingly. We know you do it because you really are working on the best interests of your patients. But huge thanks, and we will follow up. And I think what we've heard in terms of some of the groundwork, in terms of expert panels, I think this is a great opportunity for think about how do we actually help establish those on behalf of the whole rare disease drug program. And I'm going to close off this panel then, and we're going to move hopefully very quickly into Bill, who's going to take us into the international panel. Bye-bye. Thank you guys very much.
Thanks very much, Durhan. And thanks
Hard
to
act to
Joan.
follow. Sorry, Bill.
Pardon? Oh, it's all
Hard act
good.
to follow.
Definitely a hard act to follow. And I'd like to see my my panel come up. I don't know if Dave, if you're there, and Ed and Brad. We've got a half hour, so not too much time.
Hi, Bill.
Hey, Dave, good to see you. How's Edmonton today?
Cold.
Oh, but it flies back and forth between cold and warm, right? You're going to be 30 degrees next week, I'm sure. And just a quick check. We've got Ed here, great, and Brad is coming too.
Morning, everyone.
Welcome. So this is truly a Canadian panel, although we're going to be talking about international experience. We've got people in Edmonton, the Greater Toronto area, and Brad, where are you calling in from? Are you in Halifax today?
I'm in Halifax, yes, Bill.
Excellent. In the Atlantic bubble. Well, welcome. Thanks so much. We're going to talk about the international experience, and different elements of this this issue came up yesterday. People were saying, look, other countries have figured these challenges out. Why can't we? There was a lot of head shaking. At the same time, there were some really interesting ideas that came out of the brainstorm and the breakout sessions. Things like, why do we review everything that comes through as a potential therapy? If it's under a certain amount of budget impact, why don't we just provide access, collect data on it, and report on it later? So we know that these initiatives are happening around the world, and we're very privileged to have Professor Dave Menon from University of Alberta here with us, whom I've known for a very long time, talk through a few key parameters of rare drug access programs in other countries. We've got a lot of slides from Dave and the group at PRISM to share with you. We're not going to get through all of them in huge detail because we only have a half an hour, and we want to get the reactions of Ed and Brad to that. So just quickly introducing our panel. Dr. Dave Menon is Professor of Health Technology and Policy Unit at the School of Public Health at the University of Alberta, but really extremely knowledgeable on what's happening around the world and in Canada. And I think I love the stories that you tell about coming to Ottawa and basically starting the predecessor of the Canadian Agency for Drugs and Technologies in Health when it was called CODA back in the day. So really coming with the Canadian experience on health technology assessment, but your team has done amazing work reviewing what's out there globally. Ed Dybka is President and General Manager of Ipsen Biopharmaceuticals, and draws on over 30 years of experience in the pharmaceutical industry. And Ed, what you've done recently over the past few years, watching closely what's happening at the federal level and the provincial levels, for example, on the Health and Biosciences Economic Strategy table, I think really positions you well to say, look, this group looked at what was happening around the world and we tried to apply it to Canada. I'd love to get your reactions to what Dave's going to present in terms of what's working elsewhere and what are some of the roadblocks to actually getting those in place here in Canada. And last but certainly not least, Brad Aylward. Brad, I haven't seen you in quite a while. An MBA, a pharmacist. Many people got to know Brad when he was leading a lot of the programs out of Nova Scotia, and especially leading on the operations of the Pan-Canadian Pharmaceutical Alliance, probably back in the days, even when it was the Pan-Canadian Pricing Alliance, and you probably led that name change. So with that, Dave, I'm going to control the slides. Let me know when you want me to take the slides off and we can go to discussion. Okay, that's an encouragement to move through relatively quickly. But over to you, Dave. Just let me know where you want me to go next. Okay.
Thank you, Bill. I am Dave Menon. As Bill said, I'm a professor of health policy at the University of Alberta School of Public Health. But I actually work for Tanya Stavinsky. And Tanya and her team are the ones here in the Health Technology and Policy Unit who actually understand the international landscape with regard to access to drugs for rare diseases. And she was supposed to have been speaking today, but she had a specialist dental appointment that could not wait. So she gave me a bit of a brain dump, but I am a very poor substitute for her. In fact, until Bill just said, I wasn't aware that there were going to be slides. So, and so that does leave me at a bit of a disadvantage. Maybe the best thing, if I could, rather than go through the details, Bill, let me first, how many slides are there?
Well, Dave, I was just going to show, if you were going to do 2 slides, it'd be these two, just the 2 slides to say, look, it's done differently in France, Germany, UK, Italy, and Spain, but don't feel obliged to even talk to them. We can take the slides off if you want.
No, you might want to leave the slides on, but let me talk because it does cover in a more general sense. What we talked yesterday, Tanya and I, was try to address the question that Durhan had, or you had to the panel, which is who does it best? The assumption that there is somebody who does it best. There is always the assumption, it seems, that it is better somewhere else. But the difficulty with what you mean by best depends on what you mean by best. So if you, and this work, you know, Tanya and the team, as I said, have spent a lot of time talking to people in jurisdictions and so on over quite a period of time. And so this is based on that. So the conclusion will be that if you wanted to look at the shortest time to review and the program that offers the greatest opportunities for patient input and also lead to the most comprehensive basket of publicly funded specialized therapies, there isn't one. There isn't a single international model that does best in all of that. So it's all about trade-offs and what you value, which is why there are these differences, because values do differ. The other point that Durhan made at the beginning about the complexity of the environment in which drugs for rare diseases, you know, exist. I mean, in Canada, it's worse than some other places because of the different jurisdictional stakeholders, the players like CADTH, like PCPA, and PMPRB. All of these make so you get conflicting values, you get different views on what matters. So if it's about quickest temporary access to new therapies, the model in which drugs are automatically reimbursed for the first year following regulatory approval, that's the German model. So that, you know, for the first year, it is automatically reimbursed, but it may end after a year when it will have to go to their formal HTA process. But we are seeing that, or they're seeing more cases in which a company and payer cannot come to an agreement on a price, so a full HTA is required. And so you get a longer time before the therapy is available. If you're concerned about the time to actually complete the review, France and Germany have attractive models, as long as, I think you mentioned this, Bill, the budget impact is below a certain threshold. If, you know, if it's not going to cost above a certain amount, let's try to get that product in. Because they consider, France and Germany consider that therapeutic value is considered proven at a regulatory approval stage. So they don't go through an HTA process. And you can imagine the challenges we'll have trying to implement something like that in our federation. The other program in the UK, there is a so-called highly specialized technologies program, through which some drugs for rare diseases can qualify for review. That typically takes the longest time to complete a review, but it's most inclusive in terms of engagement, transparency, and all of that. Now, if transparency is most important, as just mentioned, that you can find all kinds of publicly available information on the processes in the UK. But this is a problem trying to understand in other countries where the language is not English. And so, we really don't know. But while it may be hard to judge transparency, in Germany and France and Italy, there have been complaints from patients and industry that the processes are not transparent. Few would argue that the UK's highly specialized technologies process is one of the highest levels of transparency. The problem is that in recent years, fewer and fewer therapies seem to be going through this program because it does take long, among other things. Now, if you want to have the right to appeal, except for Australia and the UK, there is no formal appeal after a decision is made. During the review process, there could be interaction and iterations. But after this decision, there can only be a resubmission. Australia and the UK do offer opportunities. And if patient engagement is important, Italy has absolutely zero patient engagement. But there's some benefits to the Italian program for other reasons. Other countries, mainly through patient engagement, is like in Canada, through submissions. There is no jurisdiction where a patient with a specific disease gets to sit on the review committee for a product for that disease. And no jurisdiction allows patients to be involved in defining stopping criteria. One of the things all countries do in different ways is they offer the option of real-world evidence-based contractual agreements. And these could be based on clinical or financial measures. So for example, you project a certain cost for the drug depending on the price per weight, body weight. So there might be some fluctuations between what you think you're going to do and what you actually end up costing the system. So in a very quick run through, Bill, those are the things that seem to stand out. So basically, I think if I could make a statement from, as an academic, I think we're looking far too much to science to try to solve this problem. I think if you look at, whether it's Health Canada's consultation or, the discussion at the provincial level about a supplementary process for drugs for rare diseases, my own view is that we're making things so complicated because frankly, the methodologists have got too much into it. And this is working in a political milieu, which I think we have to recognize and understand that, there are some things that you will have to give, and we can't use formulaic ways of deciding what should be funded and not. That's my own personal view. And I'm sure many of my academic colleagues will not agree with me. But the short answer is that there isn't a single gold standard model. It depends on what it is you consider most important.
Thanks so much, Dave. That was a terrific intro. I'll take the slides down now. We can always go back to them if needed. Your last point about methodologies clashing with expectations on the ground in clinics, et cetera, is really coming out. And it was mentioned yesterday. I just want to bring it forward in the context of COVID. You've got a national advisory committee in Ottawa that's saying, people aged 65 and over should not get the AstraZeneca vaccine. And yet in Quebec, they're going to go and give it. In other provinces, they're going to do different things. And you've got CADTH in Ottawa as well, saying, we don't have enough evidence to really say that these new therapeutics that can help keep people out of hospital or shorten hospital stays actually work. And so the methodologies are really being tested on the ground in COVID, which is affecting all Canadians. So maybe some of that issue will actually be taken over into rare. I want to turn it over to Ed. Do you want to react to the buffet of potential ways to deal with this, and then what are some of the challenges in actually bringing the best of that buffet into Canada that you've perceived in your decades-long leading in the industry in Canada.
Yeah, thanks, Bill, and good morning, everyone, and thanks for inviting me here today to this very important session. So, my reaction to what David said, I think I completely agree with what he finished up with saying, is that we in Canada are making this far more complicated than it needs to be, and frankly, what it can be to get any progress. And as I reflect on the slides that were just presented of the different models that exist around the world, I think the ones that seem to have the most appeal would be Germany and France. And interestingly enough, I would categorize my reaction as being, who does it best? It's frankly those who do the least, right? I mean, in terms of reviews and processes and all these complex analyses that we keep on expecting to try to find. And as Deb said very eloquently, is that it just doesn't, we put too much reliance and hope in trying to find the science for the answers. And sometimes you just can't get it, especially when it comes to rare diseases. We all know the challenges of getting the data that you need to make a scientific decision. So we need to acknowledge that and move on. And I'll just, the last thing I'll say is that what's it going to take for us to do some of this is frankly, and again, David said this very nicely, political will and leadership. That's really what we need to do to make some progress here.
Thanks very much, Ed. Brad, what are your thoughts on Dave's, opening and review of what's out there and what we could bring in here? I mean, I understand you're advising all kinds of people throughout the system right now in order to navigate this. Are there some elements globally that you'd like to see incorporated into Canada?
Yeah, thanks, Bill, and thanks for inviting me, everyone on the CORD organizing committee. I'm honored to be here, humbled, and hopefully I can contribute a little something. I'm far from an expert in the international models, but as Bill said in the beginning, I've had the opportunity, I guess, to kind of work within the machine over a number of years, and having spent the last 3+ years advising pharmaceutical companies, often in the rare disease space, I've had a chance to kind of continue on with that. It's always insightful, I think, to look at best practices, and I think it's not particularly surprising to say that there's trade-offs out there. So depending on what might be perceived as kind of the primary objective, whether it be speed or kind of wide access, there's always going to be some trade-off decisions. A couple of the thoughts that came to mind as I heard the other members of the panel speak, and certainly through my participation yesterday, is, although the Canadian system may not particularly highlight these as examples, there are, I think, a few examples that are shrouded behind confidentiality provisions, but where the Canadian system has, at least on a handful of occasions, gotten a little bit innovative and done things like employing clinical panels and the handful of clinical experts that might reside within Canada coast to coast, and engaging them to help supplement cases where there was a lack of evidence that our systems are kind of comfortable with. So to engage clinicians and kind of make a quick decision to say, look, we're not going to have a whole raft of randomized placebo-controlled trials adequately powered to make evidence-based decisions. We're going to have to supplement that with experts or expert opinion and insights from clinical leaders to help establish, eligibility criteria, evaluation, continuation criteria, and where appropriate, discontinuation criteria. So having worked in Nova Scotia, I'm a little bit familiar certainly with the Fabry situation. And although that whole model, I think, kind of came about a little bit by accident, but also out of necessity, it is even an example that sometimes the public payers point to and say, hey, we've done some innovative things before. And certainly in my more recent experience around some of the more contentious or kind of rare disease files where the clinical benefit was obvious and the public payers and the system knew they had to find a way. That although these lessons I think were learned from hard knocks with some files, unfortunately, that were kind of kicked around and spun around at various levels within PCPA and the broader public system. There are a couple of examples where, you know, decisions were escalated right to kind of the executive level almost immediately, recognizing that, you know, perhaps the systems that were in place to evaluate drugs, which were used for kind of common diseases, and also PCPA and negotiation approaches for general medicines, you know, that serve larger populations, are perhaps not, you know, fit for purpose. So there was at least a recognition at some point that, you know, we're going to have to make some decisions here without perfect information and without necessarily hard and fast recommendations from our agency. So we're going to pull together experts and engage and try and make the best decisions we can. The final point, I guess, that I'd make is comment around kind of the data, the collection, the real world evidence. I would say kind of sadly, but optimistically, you know, Canada and the Canadian system is probably still very much at the early stages and perhaps are only just kind of acknowledging and realizing that at some point systems are going to have to find a way to deal with these types of situations, which is at least a start. I know that through PCPA, there have been a handful of kind of outcome-based agreements where risk and uncertainty can be shared. Maybe to date, those agreements are based on administrative data as opposed to clinical data, but it's a start. You walk before you run. So I think that there are some of the elements from the international systems that perhaps can be better or maybe not so well suited to the Canadian system. But I'll pause there and kind of let you take it over, Jerry.
This is great. Brad, thanks so much for those comments. What I heard is that there's hope that even in the Canadian system that you can actually get to access without, you know, having to have a TikTok video to raise awareness about this specific challenge and get access. And I think that's one of the real challenges. I mean, there are a lot of the people on the line today, you know, have actually walked in protests, have you know, started, you know, innovative GoFundMe campaigns to try to get access to medicines and to get the attention of elected officials. But there are some ways in Canada for certain medicines to get through without, you know, the twins coming on and sharing a video like that. I don't know, Dave, and maybe your team, is this endemic to the world? I'm just looking at that threshold. It seems relatively straightforward for some very rare diseases to get access, that they wouldn't even have to go through all those processes and methodologies to even have to do that TikTok video. Any thoughts on that?
Well, Bill, if I may, I finished, I think, at the end talking about one thing that seems to be common, and I think Brad alluded to this too, and that is collection of real world evidence and contractual agreements. Almost every other jurisdiction has those. We don't hear much about some of them because some of them are confidential. However, they do happen. And to me, the problem I see here is that we are trying to do that as well, I think, at a system level, but we're complicating matters. You know, I think if you want to collect real world evidence, it should be very specific to answer a particular question. And sometimes I think we just get hung up. You know, there was a joke, Bill, you talked about when I was in Kota, and that was like 30 years ago. One of the pharmaceutical company folks that I dealt with when they realized we were going to get into the drug business he said, let me ask you a question. Do you know the difference? I may have asked you this, Bill, but do you know the difference between a methodologist and a terrorist? And I said, no, what is it? He said, you can negotiate with a terrorist. You know, and to a certain extent, that is true. And I'm digressing, but I think the real world evidence part of it, and it also fits in, I think, nicely with the part of at least the Health Canada consultation. I was one of about 20 academics invited to a specific part of that consultation. And one of the things that came out of there were a couple of things. One is what they're calling generically pay for performance, which is in a sense real world evidence connection. And the other was that the federal government ought to invest in national disease registries, because I think those are the things that will help this real world evidence to be actually collected reasonably. I mean, of course, there'll be priorities. Of course, there'll be competition for it. But I think, so I mean, I would agree with Brad that there's some learnings there that I think we could probably move on. But again, it's not, if anything, it's not going to be the science that moves it forward. You know, there's got to be the window open, as you know, Bill.
Yeah. So speaking of the opening the window and then what to do once the window is open, it sounds like you agreed with Ed in terms of do less, and that's something that struck Ed when he looked at your slides and walked through about what's happening. It's less complicated elsewhere, and you're also saying do more on real world evidence. I want to bring it back to Ed and say, where is the do less? If you could say you've tried to bring research to Canada and then bring products all the way through the line. What would you cut out from that 2-year, 4-year odyssey sometimes on medicines that we have right now?
Yeah, I think that the key issue here is time, and that the time it takes for patients to get access, ultimately getting medicine in their hands, is as we know is far too long. And the best way to deal with that, to answer your question, Bill, about what can we reduce or do less of, is the assessment and the analysis that Dave referred to. We keep looking for data that's not going to exist. If you have a rare disease with 30 patients in Canada, maybe a couple thousand around the world, it's going to be hard to get the critical mass of evidence to help make a clear black and white decision. And so we need to reduce or eliminate as much as we can the bureaucratic review processes that exist, because as we all know, they just don't apply to rare diseases. They apply to a diabetes drug where you got millions of people and there's tons of data available, but in this space, it just doesn't apply, and we need to acknowledge that, recognize it, and move forward with less information, as they've recognized, is that we've got to be comfortable making some decisions to move forward without the perfect information. But what we can do is create the systems that will help us track the performance over time. And so by doing that, we can then reduce the time for the medicine to get into the hands of the patient, and then we can assess over time. People need to realize most people don't want to take medicines. There's this somehow underlying belief that everybody wants to take medicines. Most people don't want to. They take them because they need them, not because they actually like taking them. And so if a drug doesn't work, people are going to stop taking it. And I think that we don't need to have all these interventions and analyses to determine that. Let the people decide whether something is actually having any benefit or not. Patient-reported outcomes in a real-world setting.
Thanks very much. Well, I'm hearing do less and do more. Collect more data, review. Don't over-review drugs before making a decision, because you won't have the perfect information in all cases, especially in rare. We're actually running a little bit late. I know we started late, but I'm going to go to the last question, if that's okay, which is, as you know, the federal government has earmarked $1 billion for rare diseases, starting in rare disease drugs strategy starting in 2022. What's the best use of that money? And that's the last question I'll put out to everyone. And we'll start with Brad and work our way back again to Dave. So Brad, if you had $1 billion, bare naked ladies, start singing, whatever you want to do.
Yeah, I'm going to pick up on a point from yesterday, and I don't have the raw numbers, but it was highlighted that if you look at the spend on drugs for rare diseases in the context of overall spend on drugs, and then again in the context of overall healthcare, it's relatively small. And showing that as a percentage, I think is helpful. But to be able to put it in better context, I think, for stakeholders and decision makers, let's get some raw numbers, because I'm not really sure how far $1 billion goes. But if I was to kind of give some top line advice to the people who are ultimately going to make these decisions, here's what I might suggest. Number one, please resist the temptation to develop a whole new standalone grand program. And don't recreate the wheel. I think that whatever investment is made with this $1 billion, it needs to be leveraged, as was highlighted yesterday. So we need to make sure that we can kind of piggyback on the mechanisms and the delivery that exists kind of in the provinces and work with current payers. So we don't want to kind of have this federated Canadian model where, you know, different levels of government can kind of point fingers at each other. And this might be a little naive on my end, but you know, if the feds really want to leverage that initial investment, I think they need to find a way to incent the provinces and other payers to kind of come along. And you know, maybe it is as simple as kind of saying, hey, we want to give some relief for the money that is currently or has been spent to provide treatments, drugs for rare diseases. Once we've got a sense of that ballpark, we're not going to take the whole billion and give it to the provinces and payers with no strings attached, but allocate a certain part of that to kind of say, hey, you know, as part of a federal transfer back to help supplement and provide some early relief on some of your costs and expenditures. Here's a portion. And that kind of model, I think, could perhaps continue and then be scaled over time. Really high level, love an opportunity to kind of dive into some of those ideas deeper with people who know much more about this than me, but love to hear what the other panelists have to say as well.
Thanks, Brad. Ed, if you had $1 billion.
Well, I wouldn't be working, that's for sure. But if it was for medicines, I would concur with what was just said. Is that you know, let's put the money to good use in terms of, and the most immediate good use would be towards getting the medicines into the hands of patients. Because Brad is 100% right. That's what has struck me along this entire discussion, is that of the 40 billion spent on drugs and distribution of drugs in Canada, rare disease, if you paid for every single rare disease drug for every rare disease patient in Canada today, I've read estimates that it would be around $1.5 billion. So, you know, it is a small budget item in the grand scheme of things, and I would just put that money directly into the hands of patients. But from a more systematic approach, I would create a rare disease drug czar, somebody who can make the decisions overriding all of the systems that exist in this place, just to make sure that those medicines get to patients quickly.
Thanks, Ed. Last word to you, Dave.
Thanks, Bill. Ed and Brad have come up with some great ideas. What I would add, I'd step back a bit. I think the real issue is not really budget impact, it's unit price, you know, the perception. So two things that are issues with decision making are uncertainty in this area, which is connected to heterogeneity and not understanding the cause of the disease. And secondly, the price. So the price is something someone else will have to deal with. But certainly, the federal government could incent the provinces by funding at least a few rare disease natural history registries, because that will in one way, you know, at least reduce the amount of uncertainty that is always thrown up as, and ultimately the evidence isn't good enough. So that's what I would suggest.
Thanks very much. And maybe those registries could be tied to the centers of excellence that we've been talking about.
Yeah, absolutely.
Part of the clinical networks, and they would be platform-based, like metabolic rare disorders would be something that would be separate from, you know, other rare bone diseases. For something like that.
One last thing on that, Bill. If I think it's in Italy where there are these disease registries and they're funded at the national level competitively. So a center of excellence could compete because they can demonstrate the capacity, capability to manage data for that, you know, cohort of patients.
Amazing. Well, I think that this panel should go on a trip to Italy, France, and the UK and do some outreach to learn a little bit more. But we can't right now because of COVID. So let's everyone go to the vaccine soon. Durhan, thank you so much for pulling this panel together, and Brad, Ed, and Dave for it's great to see you. I'm hoping that, you know, within the year we'll be able to do this properly in person, and I think we're going to go to workshop next and build on this even more. And I think this has been a great kickoff into that. So I'm going to look for where there are Durhans over there. I'm going to mute and say goodbye for now. I'll be back in less than an hour. But thank you again, everybody.
Thank you, Bill. Thank you, Durhan.
Take care. Be well.
Thank you to this amazing panel. This was absolutely fabulous, and it was lovely to see Dave again. So I'm really thrilled that Tanya kind of put you together and shoved you out there. So you sounded good saying what Tanya would have said. You did well. I'll tell you did well. She won't disown you.
Bye-bye all.
Bye. Thank you so much. And definitely huge thanks to that great panel, because it is the kickoff that we need into the breakouts. Like yesterday, for those of you who were here, we're going to move you automatically into breakout sessions. And we'll take a little look to make sure that there aren't any orphans. Some of the sessions may not get as filled up as all. Here's the task that you've got, and it really builds exactly on what it is that you've got. If we can, quite frankly, if you can pop up the agenda first before we go to the specific conditions, that might be a little bit easier, because I'll give you your task and then I'll show you the scenarios that you've got. What we'd like you to do is to, in your breakout sessions, to be able to consider what are the kinds of elements, the aspects of a rare disease drug strategy that need to be addressed. So we're going to give you 4 diseases, which we just talked about. So won't be any surprise. They're not really strictly the disease, but some versions of it. What we'd like you to do is take any 2 of them as sort of your guidance for how we're going to deal with this. And first of all, what we want to do is, if we're starting with a patient-centered approach, what's the need? What is it that these patients need? And what is the, is it that they need an urgent access to life-saving therapies? Do they need a program that would allow them to get access because there isn't enough evidence that needs to be developed? Is this a long-term therapy, but because we've only just introduced it, there could be, as there is with the, is this a preventive therapy? These examples and really think about, okay, what is the need that the patients have when these drugs are coming in? Okay, next part, to slow down and choose, what do you think is the best way of characterizing? 1 or 2 characterizations. Then what are the pathways? So you saw in this last panel, there are many pathways by which one might go in terms of being able to explore the ways in which we're going to make these available. Which of the following pathways, then if we scroll down, would you look at? Is it an early access program for urgent needs? It's some managed access. It's a financial pooling, so that if you've got disparities across the country, we can make sure it gets evened out. Is it some pay for performance programs? So put people onto therapies, monitor how well it works, and then we can pay on the basis of how well it actually works. Do we need patient registries? And do we need a consolidated funding pool? These are not mutually exclusive, and you may come up with others there. So, but what are the elements of the actual pathway that you need to consider? And then the last thing we want you to consider, building on yesterday as well as this morning's talk, what aspects of the rare disease ecosystem, a strategy, do you need to also have? What about patients as partners? What about having, the real collaboration, et cetera, between the public and the private payers? What about having a competitive pharmaceutical sector, the way I think people have talked about? Do we need to have some homegrown kinds of competition or competition among them? What about a network of clinical expertise, and including the networking, hosting the patient registries, a single decision-making framework, et cetera? So I'd like you to think about, choose a couple of these scenarios. We're going to show them to you, and you'll have them in your breakout groups. Decide what you're going to want, what the need is, what the aspects of a pathway should have in it, and then also what do you think in terms of the ecosystem? So here are the 4 conditions. The retinal condition, which is as you've heard, it can progress to total blindness. We've got the first ever gene therapy. It really only works for about 5%, about 200 patients in Canada. Optimal given around adolescents, but they need to get it at the right time before they've lost too much eyesight in order to benefit from it. But the caution is that there may be 20 other gene therapies that are in development coming down the road for other variations of retinal disease. So this is not going to be the only one. The neuromuscular disease, as you've already heard, there's 2 options in terms of treatment. One is, in fact, providing the protein on a regular infusion basis. The other is a gene therapy in which you inject the gene, and hopefully it will continue to replicate and be able to provide that protein on its own. The challenge is that it has to be given very early and works best if the infants are pre-symptomatic, in which case, there's a narrow window again in terms of getting availability. The persistent lung infection is a bit of a variation on cystic fibrosis. You heard yesterday some of the concerns around it. We didn't address it too much today, but we've got a current therapy that is available for about 5% of the population, still not available to everybody, but it only works for a narrow genetic variation. There's a combined therapy that's been approved, at least in other countries, and it could serve 90% of the population, but hey, guess what? It still is just in its early stages of review, and there are 90% of the patients, some of them who have urgent need, that are seeking special compassionate access. And the last one, back to the bone diseases, where we've got that low phosphate level, could be treated with drugs that increase the phosphate level. The challenge at the moment has been that it's only been done in clinical trials with children with severe conditions, but there are children with less severe versions that also suffer from having fragile or bones. And there are also adults who could be indicated in terms of getting access to it, but in fact, the reimbursement has tended to be very restrictive to just the infants. So what's the need here in the patient community? And then how would you build it? So I'm going to stop there, and you're going to get taken into your automatically into your breakout groups, the same as yesterday. If you could please, you'll have maybe a half an hour to go over this. So this is good. Choose a lead in your group among yourselves, and choose somebody who could be the same person who will scribe and be able to provide us with the notes, because we want a record of your conversations, but also then we'll report back when we come back at the top of the hour at 1. Okay, so you, I think that's enough in there, and there will tell you, oh, the document, oh yes, I'm sorry, yes, just to let you know, the document will be in the chat line. So if you need to look at it again, in terms of the 4 scenarios, it will be in the chat. Okay, ready? I think we're going to move. And maybe have a bit of a discussion. All right, I think most people are back, and I don't want to waste the time that we've got. So what we'll do is maybe get some rapid feedback. I think there were 6 groups, so we should be able to get feedback from everybody. Just tell us what diseases you chose to focus on, how you characterize the need of those diseases, if that's the way you went. What kind of pathway did you consider in terms of the best way to be treating those patients? Was it the same? Was it different? And then what else do we need? And I know some of those discussions took place somewhat simultaneously, because I was in one of the groups that did such a brilliant job of kind of looking at all those factors. So why don't we just start with group 1? Who's reporting back to, whoever knows that they're in group 1, who's reporting back from group 1?
It's me, Danielle. All right, go.
Okay. In fact, we didn't really choose a specific disease because we thought that all the disease had the same issue, so on. So regarding the addressing the challenge to unmet needs, so the main one was to provide early access with early treatment, to provide better quality of life and avoid poor prognosis for the patient. So we need to take into consideration, the age when the disease is coming, the severity of the disease, and the progression of the disease. So those who's having, very quick progression should get, really early access. We discuss regarding gene therapy, where it's an opportunity because, it's one medication at one time versus multiple treatment. However, the question was, what will we do if the gene therapy is not working, and what will be the next treatment for those patients, and what will be the alternatives? So we didn't have the answer to that. So, and regarding the unmet need is, to provide access and transparency to all the patients. And however, we could see also there is kind of a inequity, not only in Canada between the provinces, but also between the country, because North America and EU could have access where we had a representative from India, where in those countries, it's much more difficult to have access to a rare disease drug. Regarding exploring the pathway, so Christine White was part of our panel, and she says, for us, it was very important to create, guidelines to initiate the treatment and get equal access. And one of the points that at the beginning was missing is the quality of life. And now in the guidelines, quality of life is included. So. And also collecting real world evidence, it's important. And also having managed access agreement between, the payer, the manufacturer, and sometimes we should or we could include the patient. For example, in Alberta, the patient in some case need to sign an agreement regarding receiving that drug, and it is to make sure that is agree about the guidelines and when the medication is not working, so we need to stop the medication. So maybe this decision process which is implemented in Alberta should be extended nationally. So
great. That was a real strong tour de force. So I'm going to ask group 2 again, if there's some things that have already been mentioned, you could just say ditto, but also if there are things that you want to expand on. So who's reporting for group 2?
I'll go ahead and report for group 2. So for group 2, we looked at 2 cases. The cases that we looked at was SMA and CF. And so for SMA, it was noted that early access to treatments and considering treatments as urgent or addressing urgent needs was there, but it was underpinned by access to newborn screening. So that those 2 things need to occur at the same time and was important together. The other piece that was mentioned as part of that conversation was around the HTA. When we're thinking about SMA, for example, and thinking about the young family that was on the call today, thinking about the impact that the condition has on the family, on health economics, not in terms of the health resource utilization for the 2 girls, but also the impact it has on the parents as well. And so incorporating impact on caregiver experience and livelihood as well there. It was also highlighted the importance around patient registries, global registries, and leveraging that in terms of making decisions with providing early access. In terms of CF, we noted that while the treatment would respond well for or address the needs of 90% of individuals with CF, there could be differences in terms of their subtypes. And so for that reason, we proposed that a managed access program would be best here. We thought that the early access is important, but it would be best to do this through a stop-start approach through managed access. and really leveraging clinical expertise. And the last thing I want to say is we had a good conversation also around leveraging our current opportunity right now with the pandemic in highlighting the need to learn from these case examples, whether it be SMA and CF, to inform the new rare disease strategy.
Excellent. Very concise again, lovely. And you covered all the bases there, Hamir. So hopefully, we'll come back to it. Can I get feedback from group 3? Who's doing group 3?
It's Michelle.
All right.
I'll try feedback. I guess I'd have to say a lot of dittos, but we really focused on the retinal disease, but found that it was applicable really to all of them. I think the screening was number one, and it's also like in particular for the eye diseases, children are screened before school, but once they get into school, often not screened. So, and that's when things happen. So, so that idea of, screening prior to birth with family history and starting to highlight those things. And I think the other things that I clicked all of our details into the chat box, but I think we were talking about that whole notion of the real world data and real world evidence that yes, there are multiple variants that might happen depending on the gene that's affected, but don't stop and don't not treat because there might be a better one down the road. Try it, see how it works, and then renegotiate the portfolio. I think that talks to your managed access. So that was very well said. So, and I think that was everything else. I think, and the idea of amortizing some of the more expensive drugs across the lifespan, if you think about it, it's not the cost of the drug, but it's also the benefit. And I think that was so said as well. But the idea of amortizing, can you take a very expensive therapy and look at it over 5 years or something and see how you could renegotiate that. So anyway, that was 3. I think that's it.
That's brilliant, and so much appreciation for putting it into the chat. We can look at it again and we'll have it as a record. So that was a great and very concise. So we're into group 4.
Thanks, Durhan. We looked at specifically the low phosphate weak bone as well as SMA, but like the other groups, we think that many of the comments we came up with are applicable regardless of the disease state. And I think we've made comments and kind of suggestions across all the elements here. So around pathway, around unmet need and the ecosystem. So lots of dittos, of course. Maybe a couple things that jumped out, and I'll ask my group 4 colleagues to kind of pick me up here if I miss one. There's a suggestion that maybe there's an aspirational goal to find at least a couple of trial or pilot projects to see if there's an opportunity to provide access at Health Canada approval. So really try and back up the sequential review, engaging clinicians, while they're supplementing what's been provided to Health Canada, and whatever kind of deficiencies from an HTA perspective, the realities of the evidence dossiers are being recognized. Engage those clinicians so that it could be an aspirational goal of the system, be able to provide access kind of at NOC. Maybe not in all cases, but at least just an aspirational objective to see if it can be accomplished. There was a really great point raised about, perhaps the challenge with the HTA processes and systems around kind of clinical criteria being extrapolated directly from clinical trial inclusion criteria. And because of the nature of many of these diseases that are being looked at, the trials have to be designed to include and exclude some patients, and kind of the natural takeaway from CADA seems to be, well, okay, whatever evidence might be available is now only applicable to those very specifically defined subgroups. So, it was kind of a call to say that there needs to be a little bit more flexibility in the system to kind of extrapolate benefit across, broader sections of a rare disease, and not overly kind of pigeonhole into very, very specific areas. And maybe just a couple of other key comments is that I think it was suggested that CADIF in its current structural form is almost certainly going to have to play a really key role in evaluating certainly any evidence that's collected along the way, just because the provinces are not suited to do that. And if there's any hope of consistency it needs to be done kind of in a collaborative way. So perhaps CADF is the most natural place for that. And I guess, you know, maybe more of a comment and less of a solution suggestion at this point, but the whole infrastructure around kind of data collection, sharing, and the ability to kind of pool some data so that there can be some de-identified analysis and some insights and intelligence kind of gleaned from that data. It's perhaps another area where CADF might be tasked to be the caretaker of the infrastructure development on behalf of at least the public system.
Excellent. Thank you so much, Brad. Yeah, we are running tight on time, and those were amazingly comprehensive. I'm going to ask 5 and 6, maybe if you can just add what might be some of the key highlights that you think have not been raised, and we'll look forward to the notes as well. So group 5.
I'm going to assume we're group 5.
Sure, go for
it. Because I honestly don't know if we are, but so we looked at retinal disease and we looked at persistent lung infection. Challenges were similar. The one big thing I would mention was the provincial coverage inequities. And then the other one that's a bit different that hasn't been mentioned is defined clinical outcomes. There's really not a lot of defined clinical outcomes in this group. So that's not only collecting the data as a challenge, but also deciding what that data is. One area that I think was noted, how are they different and similar? Some are gene treatments, some are medication therapies, and sometimes there's multiple medication therapies. So the timing of when the gene therapy needs to be done sometimes seems to be more critical than the medications. And as Danielle pointed out, how far they are along in the disease is critical too, as to disease progression and how quickly you need to act. I'll just hit which pathways. We thought for a couple of different ideas, post-NOC access with managed agreements that look at patient outcomes, and that clinicians and patients need to be part of that evidence, that outcome development. Urgent access based on international evidence. So instead of waiting for Canadian evidence, oftentimes there's evidence available there, and then get into the managed access and agreement based on outcomes. For ultra rare diseases, we think why not go ahead and do Health Canada approval should activate access. And then the RWE or other evaluation takes place between the payers and the companies based on the results. So kind of the Germany, France model. There was a comment that we need to have somewhat of a unique process for ultra rare disease because it's even more critical and the data is a challenge. And the idea that it needs to be national rather than provincial, i.e. Canadian Blood Services model. It covers everyone in the country. Once they make a decision on what they're going to do based on expertise, they go there. And then the last one, that Canadian patient data collection needs to add to international evidence. We shouldn't be starting our own set of data collection based on the payers' needs. And I would argue that against what Brad suggests, I think clinical centers of excellence should agree on that data collection, not CADF, because their objective is to mitigate costs for payers. And that's important part of the process, but it's not the only part. And that's it for our group.
That was brilliant. And certainly I think came a couple of new suggestions in there. So thank you very much, Jerry, whether you were 5 or 6. Who's the last group that did not respond? One more report coming up. Or did we get everybody?
I'm guessing it's us, Doreen.
If you haven't reported, it's you.
Oh, well, I don't really recall who was in the group, okay? And we didn't really have a note taker. We didn't actually use the illnesses that you had suggested because we didn't have any expert in our group on those illnesses. But I think what we have generally is we talked about the difficulty of when you have a rare disease of amalgamating the people. And we talked about the essentialness of putting together that registry, then it needs to be done federally. And that way people can link not only to one another, but perhaps that would entice companies to come in and do some research here, and perhaps even entice doctors from other countries, because sometimes the attraction to a drug company coming in and doing research is the fact that the specialist is actually publishing papers and is involved directly. So it would show some kind of numbers, it would show some kind of statistics that would then support trying to attract specialists in the field and outside organizations to come in. And we really need the data. And I think that's the only thing that's different. We also talked about it needs to be national. It can't be provincial. And whatever level there needs to be one level that decides this drug is approved. And once it's approved, it needs to be a go.
Excellent. Well, that really did supplement to what others had said. So I won't try to recap it because I think there are some amazingly similarities, and I think in terms of the responses, but certainly the urgent need, the ability to provide access at the time of need, whether it's newborn or whether it's for an urgent condition. Certainly, I think everybody talked about the need for having some form of a patient registry, managed data, and at one level, certainly in Canada, but the ability to connect it internationally is important. And then looking at what are the system needs in terms of screening, whether again, it's at the newborn level, but regular screening for some of these conditions, including like retinal diseases, which you may not pick up until much later. So all of these, I think, were really important. Encourage all of you, make sure to send us your notes because I think there's a wealth of good information in there and will help us in terms of putting together the court submission and also sharing with others. So I thank everybody for that really, really great comprehensive discussions. I certainly enjoyed the group I was in. Sounds like from the feedback, there was tremendously good discussions across the groups and very, very good reporting back. So with that, I'm going to turn it over to Bill, who is going to take us through the very last panel, which is hugely important. And goodness only knows where it's going to go because we gave them hot topics and we're hoping that they will address them in the ways they need to be. So turning it over, much thanks again to all the leads and to the scribes, but turning it over to you, Bill.
Thanks so much, Durhan. And as we discussed yesterday, it'd be great if you stuck around at least to participate in some of the conversation because these are, as you said, hot topics. And I think to introduce the panel and topic really briefly, you'll remember Brad Aylward said, you know, there's an issue sometimes when the federal government and the provincial government are not necessarily lined up. And I love how you made it so visual there, Brad. I'm hoping that this panel will help actually come to ground on some of the more nutty, thorny, sticky, challenging issues. And I also remember and look back to some of the comments yesterday in the chat group. I think it was Jacob saying, you know, other people or other federations and countries have figured it out. We can too. And just another tip of the hat to this session that you helped lead, Durhan, and all the great ideas that came forward. There are solutions that are bubbling forward, and really building on actual specific case studies is key. You can't do this in abstract and hope that it's going to work or just one methodology. You need to actually ground this in patient in clinical experience to understand, okay, how will this work? Because sometimes there's 2 or 3 patients in the country. How will this work for them? That's different from other rare disease drugs. So let's I'd invite the next panel, the final panel of the conference to come up. We're going to look beyond the vision for a national rare disease or rare drug strategy. Dr. Ian Stedman, where's Ian? Looking for, start your videos, please. We're looking for Ian, Fred, Sandra, Marissa, and Karen. I'll do very brief intros. And then as we've discussed before getting ready to this, we've got one quick question for each of you to kick it off. Encourage everyone to tag in as you wish. And then the chat group, the chat room, please make good use of that. And I'll keep an eye on that as well. So you can put some questions to the panelists and they'll be watching that as well. So Ian, do we have Ian unmuted and on video somewhere?
I'm here.
Oh, excellent. Fred.
I'm here, Bill.
Excellent. Sandra?
I'm here, Bill.
Beautiful. Marissa?
Hey, Bill. Hey, Durhan.
Hi, Marissa. Great. And Karen?
I'm here, Bill. Hi.
Perfect. It's so funny with Zoom, you don't necessarily see everybody until you start speaking. So thank you. So I'll briefly introduce each of you and then we're going to kick it off. So Dr. Ian Stedman is an assistant professor at the Canadian Public Law and Governance in the School of Public Policy and Administration at York. And Ian, I remember before you, as you were just getting into law, I think, just thrilled that somebody with such lived experience in rare was getting into that world and then getting ready to apply that an analytical framework and the justice system for the benefit of rare. So it's great to be moderating you and today. Fred Horn is a senior advisor with 360 Public Affairs and principal with Horn and Associates. We know Fred, of course, is a former Minister of Health for Alberta and an MLA, but really a health policy expert with experience across the country. Thanks, Fred, for joining today. Sandra Anderson, Senior VP of Commercialization and Strategy with Innomar Strategies. And I know you began working there in 2005, and I remember working with you in 2005. So it's great to see how far you've come and how far Innomar has come. Marissa, General Manager and Country Lead for Sanofi Genzyme in Canada. And you're going to bring experience in leadership positions around the world, Australia, the US, and most recently in Canada. And finally, we've got Karen Voyne, the Vice President of Group Benefits and Anti-Fraud at the Canadian Life and Health Insurance Association. And welcome, everybody. Feel free as we jump into this, because we don't have much time. We have 9 questions and some thorny issues that are going to come forward. So make this as conversational as possible. If we get to 8, I'll be shocked, but let's see what we can do. The first question we'll throw out is to Fred. And it's about the idea, if there is a single decision maker, what should be its status, would you say? Is it an agency, an office, a coordinating body, a multi-stakeholder, multi-jurisdiction, collaborative? And I heard Ed, and you might have been on earlier, Ed Dibka say, a rare disease czar of some kind. So other ideas. Fred, over to you in terms of the decision maker or some kind of body or person.
Well, I do think it's a coordinating function, but in terms of exactly what form it takes, I really think we do so many things in Canada by deciding on the form first and not really thinking through what it is we want it to do. So whether it's a standalone agency or whether it's a coordinating body that's housed somewhere in Health Canada or with CADITH, I think the important thing is that we don't simply duplicate processes that are not working well for the rare disease community. So for example, would we necessarily want to see this put under CADITH or even the new Canadian Drug Agency, although that hasn't been described in a lot of detail yet? Probably not. Would we want to duplicate something like the PCPA with all due respect to the work that's been done there? I don't think so. We don't have, common take-up based on those recommendations. So I do think it needs to be a mechanism with some teeth. And I think if there's going to be money on the table, for the provinces specifically for improving access, then the trade-off for that is we want something that's that does have some teeth in terms of at least establishing the basic data and information structure to support decisions.
Thanks, Fred. And I think we're going to come back to that because it is the big question. Who owns this? Where does that ownership lie? And so we'll get that into that in a second. But to build on that, maybe Marissa, what would you foresee as the scope and authority of that body? Right now, we've got an acronym soup. Would you move those acronyms around and turn it into an acronym meatball? I don't know. Have another analogy if you like. What would that coordinating body do? I know. Sorry, Durhan.
Great analogy, Bill. And look, it's a complex question. There's lots to unpack, but clearly the status quo in Canada is not working, and there's an urgency to get this right. But I think similar to Fred's response, before we define the scope and the authority and whether it's a single body or not, that all needs to be underpinned by a national strategy. And that needs to be supported by an integrated and an inclusive approach. You know, our complex system was never designed for the type of medicines that we see in the market and under development today, particularly with rare disease. So diagnosing that policy problem is an absolute critical first step. And then we need adaptable pathways for non-traditional products with different features, novel payment models, risk sharing, post-market evidence generation. I know that all the things that we heard come out of the breakout groups, these are all necessary and valuable tools that other countries are moving forward. I think we see models in the UK. There's a separate pathway for highly specialized technologies, and many orphan drugs would meet the criteria established through that pathway. Some jurisdictions have adopted flexible approaches, for example, by accepting more uncertainty in the economic appraisal of orphan drugs and a higher usual cost per quality if we want to go down that road. And others have developed safety net programs through which orphan drugs may be reviewed. So I don't think there's one model, there's one country or jurisdiction where this is perfect. I think one of the advantages of being late to the game here is that we do have the opportunity at this point to implement the best practices from multiple regions and learn from their mistakes. And we should be exploring how this will work within the Canadian system. But I think whatever model we land on, we need Canada to do a much better job of setting objectives, of bringing all the stakeholders in the rare ecosystem together and working together to achieve them. And CADIS and ANES, they should establish a separate, more flexible evaluation process that are tailored to the specific attributes of orphan drugs. And then I think, as we heard as a theme, the provinces, the territories, and the federal government need to collaborate to develop, in consultation with the stakeholders, a consistent funding approach that really does ensure timely and equitable patient access to the orphan drugs. So not a magic answer there, Bill, but I think they're all things that are critical to think about as we look at what the scope and the authority could be.
Well, I think that really builds off the previous panel, which was do less of some things and more of others. And in terms of some of the more of others and what we could do in terms of tailored review programs, maybe I'll throw this question out to Ian and Sandra. What are the ethics of assessing the value of rare disease drugs using these methodologies? I mean, I don't know if you were on to listen to Dave Menon's tongue-in-cheek joke. He said, "What's the difference between a methodologist and a terrorist?" And the answer was, you can negotiate with a terrorist, and Canada is being overrun right now with methodologists. So what? I don't want you to answer that joke or necessarily, but what are some of the ethical dimensions of the questions that either that presents or what you heard earlier from Marissa?
So maybe I'll start, Bill. I think it is an ethical dilemma whether patients want access, right? And I think part of the issue is they're not getting access until it goes through a certain review process. I think if there's a process that is built on ethical stop-start criteria, where it's agreed upon early that patients can have access, and then based on outcomes, they would get certain funding, and you can call it managed access, that type of a thing. So that to me is ethical. If the patients are engaged, there's a process that's outlined and there's agreed stop-start criteria. The challenge is, what do you do when it doesn't work, the drug, and the patient has to stop? But I do think that if there's agreed upon from the beginning, it's negotiated, it's clear, and we're getting the patient on the drug sooner with conditional access, that would allow faster access. Right now, patients don't even get that. They have to wait until a year or two after Health Canada, then it goes through CADIS and PCPA. That's not the ideal process. So I feel like there is an opportunity, as the previous speakers have just said, to treat rare differently. Get the patient on as soon as possible. If they're in the clinical study, continue, collect the data, and if it's working, keep the patient on. If it's not, there's pre-negotiated criteria and there's a collaborative approach to it. And I think that's different than the models that we have today.
Thanks. And I was going to encourage the panelists also to bring forward specific case studies or examples if you can. So we might loop back around and say, in this case, you can, make it anonymous in the therapeutic area, but I think that helps put some color around you know, both the challenges and the opportunities in Canada. I mean, Ian, can you share, you know, some of your, you know, thoughts on the ethics of the methodologies that are applied today and what can be done better?
Great question. Actually, Durhan and I had a conversation last December about the ethics of qualities. So I might go down that path for a minute and wax philosophical about that, and hopefully that opens up some dialogue. Have qualities come up? I've been parachuting in and out of the conference. Have they come up in any great detail throughout the conference?
Just off and on, it's another acronym. Take 2 seconds or 2 minutes and explain equality for people, please, Ian.
So QALY, or quality of life scales, right, are used to put a quantitative measure on an individual's health status. These scales are effectively used for discounting the value of a therapy if, you know, when using that therapy, a person's quality of life is deemed to be less than perfect, right? So if the therapy doesn't lead to perfect, then you discount it based on a quality scale. I hope this is a fair description. It's kind of simplified, but if we understand it kind of in this way, you can see how quantifying quality of life can lead to some interesting challenges for not just the rare disease community, and I think, to be quite honest, the broader disability community, right? Then some challenges that I think we should be raising. So we've been using quality scales for so long to figure out the value of a drug over time for an individual, particularly in the UK and Canada, that we seem to have just accepted that a person who lives with a physical or cognitive impairment means that that person's life is less valuable than someone's who doesn't live with those same impairments or characteristics, right? That's quality of life over time, so we've given it some quantification. So I understand that when designing policies, you often have to look for a line of best fit, so to speak, but that doesn't mean that you don't go back and reevaluate that line every so often. And I think we're at a moment now where we've come to a recognition that this kind of approach is problematic, right? And it's sensitive. It's ascribing an idea of value to the lives of others in a way that doesn't seem to sit well, at least not as easily anymore. So for lack of a better way of explaining it, I think it's kind of intrinsically reductive, and it doesn't seem to do justice to the value of the lived experience of others in the way that I think we might want to do if we analyze drugs. So to bring a specific use case in, as you were saying, Bill, so I speak from my own experience as a person who takes a drug for a rare disease, right? So the medicine I take every 8 weeks costs me $16,000, right? Someone had to develop that. And in developing it, they've learned something about the mechanisms of a disease. Sure, the drug that I take is going to be under patent for a little while, but if someone's manufacturing it, then someone has come to some understanding about the mechanisms of a disease. People with the same diagnosis as me can take another drug that costs $16,000 a year if they take it daily. And right now there's a clinical trial in the States about an oral capsule that does the same thing. So if we don't incentivize getting that drug to market in the first place, the mechanisms of that disease don't become known, and then the innovation doesn't happen in the kind of other spaces in the pharmaceutical and research areas. So when we start from a starting point where we're ascribing a quantitative value to a qualitative thing, maybe we kind of disincentivize this progress and this understanding and this desire to kind of get into the space, which can really have downstream effects that are positive for rare disease research. So I'll stop there because I've talked for too long.
No, that was a very important hot topic that I don't think that we have adequately explored. So thanks, and everyone, after every one of these conferences, somebody says, "Please define quality for me," or "What does that mean?" So you've done it, and it needs to keep on happening because it's not clear for many people. Karen, I'm wondering if you could explain what the private insurance world is seeing in terms of rare and how you foresee drugs in the national program should be funded in terms of a role for your members and the sponsors of private drug plans, and where you think we're going to be going to be able to improve access for patients with rare diseases.
Yeah, thanks, Bill. And I guess, I'm speaking for private payers. I'd start off by saying we certainly see ourselves as being part of the solution and continuing to provide access to patients with rare diseases and working with governments and others to help develop those solutions over time. And I heard Marissa say earlier around it's important that all stakeholders work together on this. And I think that's one of the unique opportunities in something like the rare disease strategy, is that this is one of the issues that I think we can all agree there is a need and a real desire to work together on it. And, you know, just in that context, I would say kudos to CORD and thank you for, you know, organizing this discussion today among all the stakeholders and yesterday and over the last 6 months, actually, as you've hosted webinars. So thank you for that. You know, we do see private payers as an important and essential stakeholder in the effective development of this strategy. And so, you know, we first of all believe, let's leverage the strengths of the existing system, right? And the shared responsibility between public and private plans and the federal government to ensure that access for all Canadians who require and will benefit from a rare disease drug have that ability to obtain that drug. We know that there are important advances that are going to continue to be made and that the pipeline of rare disease medications will continue to grow over time. So, you know, the concept of risk sharing in some way, shape, or form between public and private plans and the federal government, we believe is really critical to ensure sustainability of any program that's developed over time, right? So, you know, I would say that, you know, we've spent a lot of time as an industry, and especially in consideration of a response to the current consultation around, you know, what are some potential funding options? And, you know, while we have some thoughts around that, we've intentionally not landed on a specific option, and really from the context of wanting to remain helpful and, you know, sharing our thoughts, but also being open to other innovative ideas from other stakeholders. So again, it's that concept of helping each other and helping government in achieving their overall goals. So while we believe it's important that private plans continue to, you know, provide access to patients, we also know it's going to require change, right? So the concepts of a national formulary, common clinical criteria are concepts that we support and believe could be adopted by both public and private plans over time. And so, you know, we also think there's an opportunity for private plans to be included in those drug negotiations, again, to lower the costs and improve accessibility for patients. So, you know, I guess I would say, you know, lots of thoughts around this. As I said, intentionally have not landed on a specific solution, so that we remain open to innovative thoughts from others.
Thanks so much. I'll just put a quick plug in for something that the CLHIA, you know, helped create, which is the CDIPSI. Talk about an acronym soup, the Canadian Drug Insurance Pooling Corporation. Did I get that right?
CDIPSI, yeah.
Okay, so I mean that's been in place for the better part of 10 years now, and it's an innovative, you know, fully insured small employer model to be able to spread the risk around. So it's not like CLIA has been sitting on its hands on this issue for the last couple of decades. You've been getting ahead of that. I don't know if you have any comments on that, because then I want to throw it back to Fred and talk about, you know, from the public sector, are there some risk sharing models that we could look at?
Yeah, thanks for that, Bill. And absolutely, we have had that pooling program in place for a number of years now and had some success with that, right? And I mean, we're the insurance industry, so risk is our business, right? And so, you know, we do believe that some kind of a shared model, whether it's the CDIPSI model or some other pooling mechanism, I think the important thing is that, you know, in my mind, is that it's something that's going to be easily understood by patients and Canadians in general, that it's easily implementable and can be done fairly quickly, right? Because I think, you know, we want to make sure that we're not having the same conversation 5 or 10 years from now. So thanks for that.
That's a great objective. Change the conversation 5 or 10 years ago, from now, not ago. Fred, over to you in terms of, you know, some of the things that you've seen at the national level. You know, the tables that you've sat at in the past talked about, you know, how to share risk across the country. Any thoughts on how to actually do this?
Yeah, well, there actually, you know, have been discussions amongst groups of health ministers, and I tried to start one in 2013 about the idea of a national drug coverage program for drugs for rare disorders. And surprisingly, you know, what I found was a lot of interest sort of in the informal discussion in, is there a case here that we can pool our risk and pool our resources, as Karen talked about. Lots of openness, and I think it's still true today in terms of working with private payers and having them be part of that solution. And in terms of the barrier, to actually moving forward on something like that, I'm not sure what to point to. I got to say, I think if people like me who have served in the role, if we were permitted to talk more about some of the more innovative product listing agreements that we've seen, and they're confidential, and we're not afraid to talk about them. But I mean, we have lots of experience with this in Canada. It's just we don't talk about it. And so I don't think we need to be educated as governments on how to do risk sharing or why we should do it. I think it's about having the tools and the infrastructure in place, particularly the data and the digital infrastructure and the registries, to start collecting information and making more informed decisions. There are a lot of provinces, I think, that would like to, for understandable reasons, would like not to have to deal with, on their own, starting from scratch each and every time on the reimbursement, the listing or reimbursement decisions around these drugs, right? And we see that in the attitude that's portrayed, because it's talked about as an incremental cost in the global drug budget, right? It's not really talked about at a patient-specific level. So governments, I think, increasingly the problem is uncertainty, dealing with uncertainty, and dealing with the sharing of risk, or the assumption of risk. So if we could have these building blocks in place to support better decision making, then maybe more people would have confidence in taking a national approach to this. What's really exciting about this is, we're living in an era where, we see a government that wants to be much more directly relevant to the evolution of healthcare across Canada. Whether you like them, working with your province, and whether you have questions of jurisdiction and so on, sort of beside the point. Seeing this interest in taking some responsibility and sharing leadership for a long time. So I think ministers today would be well advised to take advantage of that, and and to start to really come to the table with some specifics about what they think needs to happen. This won't be a flip the switch over the night shift. If it is a new agency, as an example, it'll be a question of what are the rules of engagement and what is the infrastructure that we need to support those decisions. To me, that's a really logical place to start, and it doesn't have to take 20 years to get there.
Excellent. Thanks, Fred. Well, you know what? We made it through the core questions that I had or that we prepared for. But because this is a hot topics panel, and because Durhan brought up in the chat panel, the PMPRB, one issue that we've heard, especially in rare and in cancer, is that medicines may not even come to Canada at all because of the uncertainty about, the Canadian system, starting with how they're going to be evaluated for price. So, I mean, maybe I could bring this back to you, Marissa, or to Durhan. Is that one of the issues that where Canada should be doing less in order that we can do more on evidence development and value agreements, et cetera? I don't know, Marissa, do you want to start? And Durhan, feel free to weigh in on that.
Sure, thanks, Bill. I'm not sure we should be doing less, but we certainly, this is a significant concern for the pharmaceutical industry. And, we've been doing a lot of work working with CORD and other associations to really try and reinforce the message to government that implementing the policy changes such as those proposed through PMPRB is going to lead to companies not launching, or at best delaying their launches within Canada, and particularly in rare disease therapies. We've seen that the HTA methodology does not work. It doesn't work now, let alone if we implement additional economic factors that the rare disease drugs have to meet the the threshold for. So this is of significant concern, and it's something that we continue to advocate for, that rare disease treatments have to be treated differently. They are rare for the plethora of reasons that I'm sure has been discussed today. But if we are unable to have a predictable environment, and we heard the word uncertainty, and I know the government certainly doesn't like to operate within an uncertain environment, but it is not conducive to manufacturers or to the pharma industry as well if we don't have a predictable path forward. And when we talk about investing from an R&D perspective, when we talk about bringing products to market in a certain time frame and tiers of different countries, we're competing with the rest of the world. So if we don't have that recognition of the value of innovation, and that these therapies are ultimately going to be made available to patients and funded, then that is going to have a significant impact on what we're able to do within the Canadian environment.
Thanks so much, Marissa. Maybe I'll turn it over to you, Ian. I mean, as somebody who's got the lived experience with a rare disorder, but looking at this from a public policy and a legal framework perspective, I mean, I'm giving you a magic wand right now. Do something to fix Canada so that you don't have to go through the same hurdles that you face to get access to the treatment that's keeping you alive today.
Yeah, well, the answer is there's no one answer, right? There's just so many different moving parts that aren't moving in the right ways with one another. For me, it's this question of how do we get it so that we can actually, how do we get it so that pharma wants to be here and work on the problems that matter to Canadians, right? And this is, again, we are a small market. We're a tiny market compared to where pharma starts out when they put a product, right, on a submission in. So how do we get them to want to come here? And it's by not disincentivizing further their willingness to come here. I wanted to kind of, maybe I was thinking something different in my head when you asked me, but I want to kind of pivot a little bit to come back to some of these questions about what do we need to do at a national level? And I like this conversation about data strategies. We do need to do a better job because of the constitutional nature, the division of powers, and the way data is, privacy is protected and healthcare is divided. We do need to do a better job of sharing across borders, because we're also seeing that things like artificial intelligence are coming in and leveraging data to predict how proteins fold, which can have tremendous therapeutic benefits down the road for innovators. And if we don't do something like that, we're not really going to build an infrastructure, right? Rare disease patients are all over the country, just a few here, just a few there, and our data is siloed. And a lot of us have too small of a patient organization to actually put together something substantial that will bring the data together. But if we had a national strategy doing something like that, then you can start to leverage this and learn from it, and maybe incentivize more people wanting to come here to learn from and do work with the data that we've kind of collected and governed in an appropriate way. So I think there's a really interesting conversation to be had about a national data strategy in the healthcare space too.
Interesting.
Move us forward.
Every time I go to a CORD conference, which is most of the CORD conferences, going back a long time, there are lots of patients and families who are traveling to the U.S. or even Europe to get that radioisotope therapy or stem cell transplant. And in some disorders, they're traveling to India for untried surgeries and experiments. I'm just wondering, maybe I'll turn it over to Durhan, who before the pandemic spent a lot of time on planes going around the world. Are we thinking too locally when we think about Canada, which is 1.8% of the global market? And can we think a little bit broader in how we can actually collect data and give people access to what the world is offering, especially with some of the patient groups that you help support here in Canada have 5 patients in Canada or less. I don't know, any thoughts on how we can get out of even Canada to do better by Canadians?
Yeah, I mean, you've had a lot of great questions that raised, and this panel has just been fabulous in terms of, kind of moving I think, some of these tough questions forward. Certainly there is, and I think we've all agreed, right? We work in an international community, so there's no doubt about it. We can do nothing in isolation. I mean, even some of the chat lines and requests come to us. I'm the only patient, in Canada, in a population in which there's 200 worldwide. Okay, well, like, if we're going to do something, we're going to have to think internationally. So there's no doubt about that. And I think we're all moving in that. The international community is coming forth with these kinds of, federated registries where people can put in their data and you can use de-identified data and share that, but without jeopardy in terms of privacy. So we're all working there and we all believe exactly the same. So I think that's happening. And, we've had some great meetings just recently. The UK and Canada came together for a joint meeting around sharing of genomic information. Again, I think the UK especially working hard, recognizing they're going to be sitting outside the EU, so not naturally you're going to have that kind of access. So that's where Canada is. So I think we are looking at it. I do think, in listening to all of this, I mean, back to where we started from, and that is Canada has a unique opportunity to actually be a leader. We've all heard there's no one model that works best. There's lots of good aspects to it. So can we kind of use the fact that there is a commitment to having, setting up a rare disease drug strategy with the opportunity to put some funding into it? And I think we all realize that, nothing's working really, really well. And I love this conversation we were having on the side here around, can we fundamentally challenge the qualities and the HTA and the ICERs? And the fear is that, I think, as Michael was saying there, we're going to all getting into personalized medicines. And so what we're evolving here for rare diseases, quite frankly, could be that template for what's going to happen with personalized medicine. So that could be a tragedy. Or it could be that great opportunity. Can we get out in front? And everybody's saying the same. What can we do to provide a climate that's going to bring in more research? And it isn't just the climate that says, here, let me give you a bucket of money and give you a free pass and what you're going to charge for drugs. But can we create that kind of a good clinical trial environment? Can we create a network of clinical expertise so that you can come into Canada and do a one-stop shopping in terms of setting up clinical trials that'd be right across the country? So we could do those kinds of things as part of this. And I think all of those are great opportunities for us. Obviously, we don't want to try to spread this all so thin that we're not going to be able to get moving. I really want to kind of ask the question to everybody, can we, so typically un-Canadian, but could we actually be that flexible, nimble environment? Can we have then? I mean, Fred says, I don't know what it looks like. Form follows function. And maybe that's the case. Let's not kind of strap it down yet. Let's not say, and what all that discussion in breakouts we're saying, here's a pathway, here's a pathway, here's a pathway, here's a pathway. Can we evolve the pathway to fit what the need is? Here's the disease, here's the drug, here's the opportunity. Is it genetic? Is it going to be a replacement? Can we evolve a pathway that makes sense for that within a framework that says we're going to be evolving it and monitoring and everything else, right? As I say, so typically non-Canadian to think of how we can actually do this without a whole set of really not tied down guidelines, right? But, Marissa kind of opened it up to say, you know what, we've got all of these opportunities and we have to embrace it. So, the challenge is, can we embrace it all? Can we really say? And I really call on the industry to come forth. When you bring me a drug, don't bring me a drug, bring me an entire program for how you're going to make this available. What is everything you need in order for this drug to be made available to people at the right time, with the right kind of monitoring, with the right kind of, ongoing research support? Give us the whole thing, right? And then, we could have, and it could be, standalone pilots that are going to help us. I mean, Fabry, everybody keeps coming back to, right? It was a standalone pilot. And, we never built on it, but, we could, right? And we could develop pilots that really say, what do we learn from this? What else could do it? Who else could do it? So I'm really very encouraged by the fact that, we've had this discussion. Sometimes I wake up in the middle of the night and I think maybe the PMPRB regulatory changes were just a spoof. Maybe somebody thought this was an elaborate kind of a scheme to really frighten everybody to death and put in the most draconian kinds of, regulations so that we would be shooting those down and rather than really where we are now. And that is, what could we evolve that would be a whole lot better? I would love to think it was just, really a great elaborate scheme that, somebody will at some point say, we were never going to do this, anything quite this stupid. But, we just wanted to get everybody kind of thinking in a different way So that to me would be great. You know, we could think in some very different ways, because we do know that you got the PMPRB on one side, which is going to be doing HTA and qualities and setting up these restrictive things. And we've got on this other side, the opportunity to create a rare disease drug strategy that could really be meeting the needs of patients and be free from those kinds of restrictions. So, you know, I choose the agile pathway, and let's see if we can build this in such a way that it's genuinely attractive.
And maybe I can add to that, Durhan, on top of your optimism, you know, we've cleanly seen over the last year what's possible when we come together in the face of a crisis. You know, we have seen partnership across manufacturers, you know, competitors that would never normally talk to each other, collaborating across industries with government. And we've actually seen how quickly we can take action. So, you know, now is the time. I think this really is a moment. You know, access to rare disease therapies is a crisis. It's a crisis for those patients, and it's a crisis for those families who are burdened with their disease. So, you know, if we can apply the learnings, the relevant learnings from the pandemic to expedite a path forward to sustainable access, you know, then that is what we need to do, and we need to do it right now. So.
And I would add to it, Marissa, I love the optimism. If we had applied some form of a quality allocation to get into vaccine, certainly would not have gone first to my husband, who has got Parkinson's, is in a wheelchair, is in a hospital. That would not have been it, right? We would not go into the nursing homes. We would not have prioritized some of these highly vulnerable patient populations. So if we can do that, and we believe that's the right thing to do, you know, I mean, because if we had applied to quality, we would have gone to, you know, many of the corporate offices, you know, where we've got, you know, high paid executives and given them the first shot, but we said no. So I think we can apply that learning as well. So we can be humane, we can be ethical, we can look at where the greatest need are and say, yes, let's go there. So yeah, great lessons to be coming out of it, but love the idea of, you know, the industry as well. You know, how does Sanofi manufacture, you know, drugs for Pfizer and do that in a cost effective way? How does Merck step in? That's what we want.
So just to, I know we're running close to the end of the conference here. I just want to maybe wrap it up.
It's over to them.
We've got
hey, we got a bomb in here. Who is this person?
Zoom bomb.
Somebody's a Zoom bombing us.
I want to really briefly show, because we dug up what Health Canada's departmental plans were. I know that Health Canada is on the line here, but I'd quickly share my screen. Their targets for next year are not to increase access to rare disease drugs. It's to keep national health expenditure as a percentage of GDP to X amount. It's to maintain real per capita health expenditure to X amount. It's drug spending as a percentage of GDP. They've got one on affordability because of cost. But I think the real point is, unless we get, you know, Health Canada and other, and actually for that matter, you know, private payers, which really represent employers and beneficiaries, to have as an aim better access as a real goal, you're never going to get them onto that different track. And as you know, Brad was saying, that we're going to be talking at cross purposes, because that's not their ultimate aim. So I just wanted to quickly share that for interest's sake.
Great. Well, I think that comes back to saying, you know, making sure that we understand what our aim is, and that we're really, you know, I love the conversation we had before, like yesterday, patient-centered, public health center, or evidence-centered. And I think we all came down to say it has to be patient-centered. And yes, the other part's important. We are going to close this out. It's right at 2 o'clock. I cannot thank everybody enough for their amazing contribution. And certainly all of our last panelist group, which was Sterling, because we gave you some real hard questions, and you really kind of came around to some great conversation. We will be doing, we're hoping, a couple more webinars. One of them might be, and I'm looking at you, Karen, we really want to talk about the role of the private payer in the rare disease drug strategy, and really delighted that you're here, delighted that you guys are also thinking about that. And we also do want to, if we can, talk about this whole quality assessment, and how do we actually want to build it into a rare disease strategy? Where should we build it? I mean, nobody says we should not have some value-based parameters, but where should they be and how should they be best used? I think that's essential. So may not be before the 26th. It may be. We're going to try to see. I think we're all tired of Zoom, so I'm tired of looking at, you know, most of your faces anyway. So, but you know, on the other hand, we really have had some great experiences here. So huge thanks again to everybody. Huge thanks to all of our sponsors. And again, I can't go through all of them individually, but it's been superb. And huge thanks as always to Angela, to Hillary, and to Sandra for really pulling in to make this work. And then big thanks obviously to Bill always for the kind of superb navigation you give us in terms of these panels. So thanks a lot, folks. You will see some things coming out. We will try to get you a draft of what our submission is going to be and how we're going to answer not only these questions, but the three main ones that are coming up in the town halls to come. Thanks again, everybody. We will see you very, very, very shortly. Huge thanks.